I'm now going to introduce Dr. Daphne Hsu, who is a professor of pediatrics, director of the Division of Pediatric Cardiology. She's a graduate of Yale University School of Medicine, trained at Columbia University Babies Hospital and Presbyterian, and then remained on the Columbia faculty. Will you be able to hear me, hopefully? Until 2007, when she was recruited to the Division of Pediatric Cardiology at the Children's Hospital at Montefiore and the Albert Einstein College of Medicine to continue her very productive career investigating the underlying mechanisms of congenital and acquired heart diseases in children. She's been a key national resource in several major trials, one involving the treatment of heart failure in children, including the challenges of cardiac transplantation. She also has developed an internal collaboration with Dr. Bernice Morrow to elucidate the role of genetic, I said it, genes, okay, mutations in the development of congenital heart disease and cardiomyopathies. We go on and on. She's participating in an NIH-sponsored pediatric cardiomyopathy registry as part of a multi-institutional prospective observational study of children with cardiomyopathy to relate to their outcomes with their genetic etiologies. And she leads one of 6 clinical sites for an NIH-sponsored clinical trials in organ transplantation in pediatrics. Please welcome Daphne.
Great. All right. Well, thank you, Brian, and I'm very happy to be here. I'd like to thank the Dean and Brian and Harry for inviting me to speak this afternoon. I'm speaking from a different perspective. I don't have large populations of patients that care for, and I don't have large, vast databases to use, and I think we also have challenges in our small area of basically a rare disease. I think that pediatric cardiac diseases is a model for how you take care of patients who are not very prevalent and who don't have the power to really look at large populations and measure what we do. And I'll sort of share with you some of the things we've learned in pediatric cardiology and some of the things that we hope to do in the future. So what are the diseases that we care for? It's a very small little specialty, so I thought I'd tell you a little bit about what pediatric cardiac diseases entail. Most of what you think about is taking care of children with congenital heart disease, septal defects, holes in the heart, valvular lesions, meaning one of those 4 valves isn't working correctly, and complex diseases where really parts of the heart haven't formed and we have a major problem in the way the blood flow flows around the heart. We also take care of children with acquired heart diseases. These are usually inflammatory. There's a very unusual disease called Kawasaki disease, which causes coronary artery strictures, rheumatic fever, a disease not as prevalent here in the United States, but certainly worldwide is a major cause of heart failure in children. My special interest is in a field called pediatric cardiomyopathies, which are a variety of lesions that are due to muscle disorders of the heart. I think a very interesting area because it leads to a lot of discussion and interest in how the heart forms and how it develops and may help us care for our adult patients with poor function. And so that area is something I'm very fond of talking about. And then heart failure in general. What happens when these hearts in the end don't work and you have a heart in a child that isn't working and the rest of the child is actually doing very well? What do we do to treat those patients? Those patients may have cardiomyopathies, and these days they also may have end-stage congenital heart disease, as we've gotten so much better in treating children with congenital heart diseases that they're surviving longer, but unfortunately not surviving with normal cardiac function for the rest of their lives. So what are the research questions that we have to answer? I think one of the things is who is at risk for these heart diseases, both the congenital and the acquired diseases. It's a major cause of concern and also hope for the future. If we can figure out who's at risk, we might be able to then figure out therapies that avoid the disease altogether. And then another is who will benefit from the therapies that we are offering our patients. A lot of what we do is empiric. You'll see the incidence of diseases is quite low, and it's difficult for us to know much based on evidence-based medicine because of the nature of the small numbers of children that we treat. So I think what we are often trying to test in our studies is the effectiveness of therapies that we offer them. Medical therapies, drugs are often offered to children based on adult data and adult literature. And as we know, children are not small adults. They have their own problems with developmental issues. Their etiologies of the diseases is often different, and medical therapies may not translate into improvement in childhood diseases. We do a lot of surgery for congenital heart disease, and quite honestly, surgeons are not very good at looking at how they do things and deciding on an evidence-based manner how they might treat children. And recently, we're now getting into the area of mechanical support for children with heart diseases, using machines to substitute for what the heart does. And that's an area that it's very difficult to assess whether or not a therapy is more effective in one child than another. And we're also looking at then predictors of who will be at risk and who will benefit. And I think we spend a lot of time looking at clinical predictors. I'm a clinician. We do try to characterize our patients based on what we see in front of us. But there is a lot of interest now in the use of biomarkers, use of genetic and epigenetic basis of disease to predict how children will do. And this area of pharmacogenomics and pharmacogenetics is becoming more important, especially in children, as we try to apply the drugs that we're using in very diverse populations. There are a lot of challenges in study design in the children and that we care for. It's really a matter of small diseases, of rare diseases in small populations. So the incidence data, just the incidence data is often sparse. Populations are not well characterized, and we don't know exactly who is affected in order to know who to study. Endpoint determination is a major issue for us because we are luckily dealing with often a low incidence of the major morbidities and mortality that you might expect. The incidence of death and significant morbidity is often quite low in our patients, which is a blessing, but very difficult then to power a study based on a major endpoint. Disease-specific quality of life measures are often not available, so we try to look at the global child health-related quality of life, how well they're performing functionally. There are not good validated measures across the age groups for us to use. And surrogate endpoints are very much not validated. So if we try to look at ejection fraction or tissue Doppler or something on a study of the heart that's qualitative, we do not have any data to show that tells us really how that child will be in the future. And then limitations of power are always an issue for our field. And we have challenges of study implementation that are unique to children themselves. There's parental reluctance to participate in a study. Often there is more than minimal risk in some of the patients we care for because they have congenital heart disease or serious heart diseases, so we have to explain that to the IRB. And there is a tremendous lack of equipoise in our field. I think that's always the relationship of equipoise to data is inverse. The more equipoise you have, the less data you have, the more times you have problems with equipoise. And we have a lot of people who are quite certain that what they do is the only thing to do because there is no data, so they have to believe that their judgment is correct. And that really does impact quite significantly on our enrollment in studies. Clinical trial infrastructure is often lacking in pediatrics. We don't have as much access to even drug studies that teach us how to do trials, quite honestly, and we don't have study coordinators who are skilled at working with children and families and encouraging them to participate in research. Pediatric IRBs can often be, rightly so, very careful in their oversight, but we also then have to have people who are very experienced in knowing how to discuss things with an IRB and what the issues are that might come up, or that can lead to a tremendous delay in study implementation. And funding is always an issue for pediatric studies because we don't deal with a large population of patients. The patent exclusivity program has actually been a big boon for studies in pediatrics and even in studies in pediatric cardiology. And I'll sort of tell you a little bit about the study we did with support from GlaxoSmithKline that really helped fund a large study that we never would have been able to perform without it. NIH funding, I think, is actually increasing in our field, and that is thanks to a lot of active support at the NHLBI, realizing that childhood diseases may help inform how we care for adult diseases because they're often pure in their evaluation of heart failure, in their evaluation of the mechanisms of disease. And patient advocacy organizations are actually quite prominent in our field. There are a number of parent organizations that advocate for us, both on the national and international level, to increase funding and increase awareness of the disease, and as a result, bring more investigators into wanting to study these diseases in children. Now, what am I talking about with the incidence of different diseases? Congenital heart defects are found in 8 of 1,000 live births, and there are at least over 20 different categories, over 1,000 different types of diagnoses if you really get into it. But they're quite a large variety of lesions that are not quite comparable. Surgical interventions at a single center range between 100 and 1,000 per year, and mostly average 200 to 300. Scattered among 20 different diagnoses, that doesn't give you a lot of patients to study per year in an individual type of defect. Kawasaki's disease, that disease I was telling you about that has affects the inflammation of the coronary arteries in children. 19 per 100,000 children are affected by this disease in the United States per year. Pediatric cardiomyopathies, there have been several very nice incidence studies both in the United States, Finland, and Australia, and the incidence is 1.5 children per 100,000 per year. So again, very rare diseases. Heart failure affects about 25 to 50% of children presenting with the cardiomyopathy, so take that 1.5 and divide it by half. That's what we're seeing per year. And congenital heart defect incidence, turns out we actually don't even know. There aren't even databases that can tell us what is the incidence of heart disease after open heart surgery repair. Pediatric heart transplantation, an area that I've done a lot of research in. There are 300 to 375 transplants performed in children under the age of 18 in the United States per year. So once again, a very small number if you scatter it amongst 50 states and about 25 centers. So how do we approach this, or how have we approached it? I would say in the 70s and 80s and even into the 90s, we've done a lot of single-center studies. All of us in the field would report on our 25 to 30 children that we treated with this particular problem. We were able to infer some incidence data and prevalence data. These are retrospective and underpowered for really almost any endpoint that you would consider clinically meaningful. In the 1980s and 1990s, I think there was a lot more interest in collaboration and realizing if we pool our resources and starting registries, that is going to help us at least determine incidence and prevalence. And so I've worked with 2 organizations for the past 15 years. One is the NIH-NHLBI-funded Pediatric Cardiomyopathy Registry that is collecting data from now 7 centers. It was 20 centers across the United States on the incidence of cardiomyopathy and outcomes. And something that is an investigator-initiated unfunded effort called the Pediatric Heart Transplant Study. We started in the early 1990s, and we now have entered over 3,000 children listed for transplant with event-driven prospective data forms that are helping us quite a lot define how we care for patients, but once again, not really getting into treatment trials or intervention trials with these registries. In 2000, in the new millennium, we are seeing now that we're starting to talk about treatment trials. Mechanistic investigations can now come into it. If we really start to investigate treatments, we have a better defined population and to look at mechanisms. And I thought I'd give you an example of sort of 2 of these studies and how they they are very representative of what's going on in our field at the moment. The first study is a study where we studied carvedilol for children and adolescents with heart failure. It was a randomized controlled trial. It was done in many centers and supported with what started out as I think it was SmithKline Beecham and went into GlaxoSmithKline. And they supported this study for quite a long time. It was a prospective, randomized, double-blind, placebo-controlled, parallel group, multi-center trial in children to study a drug in children who had critical heart failure, ventricular dysfunction with what the 2 diagnoses, cardiomyopathy and congenital heart disease. I'm emphasizing that because that was an issue in the end analysis. And we treated the children for 8 months, so actually a quite short treatment trial to see if this drug, carvedilol, which has been used in adults very effectively to treat heart failure, was as effective in children as we had hoped it would be based on the adult data. There was a composite primary endpoint of worsened, improved, or unchanged that was adjudicated by an endpoint steering committee. This endpoint was not validated in some of its markers. Certainly death and hospitalization are fairly well defined. However, worsening in a heart failure class and a growing child is difficult to really assess. So that was one of the issues as we were designing the trial, looking for a good endpoint. We made some sample size assumptions based on all of those single-center retrospective data, and our assumptions were in an untreated placebo group, 20% would be improved and almost 50% will be worsened over that 8-month period of time. We thought if we treated with carvedilol, we were going to look for 40% of the patients to have improved over the treatment time and about 25% to be worsened, or about a 50% reduction in who would be worsened over the time of the study. We were able to enroll 161 children using 26 centers over 4 years. The initial proposal was to enroll 180 children at the initial 6 centers over a year and a half. This was, I think we were the bane of the existence of GSK, but they kept supporting us, quite honestly, because they had decided to fund us to get patent exclusivity extension for their carvedilol drug, so I don't feel sorry for them. But it did take a long time. They were boys. The treatment group was 75% traditionally cardiomyopathies, left ventricles that didn't work, and a quarter of them were children who had congenital heart disease and heart failure. They were symptomatic, but most of them in class 2, so relatively asymptomatic. A young group, nice group, median age was 3 years old. They had bad ejection fractions. Their BNP levels, or one attempt at some mechanistic studies, were more elevated than you would think in a normal population. And this is our results. We are comparing the placebo group to the combined carvedilol. There were 2 levels of treatment group. So 2/3 got carvedilol, 1/3 got placebo. Yellow is better. Light blue is worse, and red is no change, and we found no difference between the 2 groups, and that was after 4 years and about $10 million. We found no difference. Now, one thing I wanted to point out to you is, what did I say? In the placebo group, we expected 20% of the children to improve, and we saw 55% improved in both groups. Now, this is also a good reflection on the investigators. I actually feel there was some placebo effect on us watching the children for 8 months. Everybody seemed to get better, but it did really upset our power calculations, and we had no power to detect any difference, but obviously there wasn't any difference irrespective of the number of patients. Now, I told you we enrolled patients who had cardiomyopathy and patients who had non-LVs at their systemic ventricle, which were congenital heart disease patients, and a quarter of them were these congenital heart disease, and these were the classic normal hearts with poor function. And guess what happened? We had a pre-specified analysis in the protocol to look and see if there was a difference in treatment response between the 2 groups, and there was. So what we saw was that the relationship of this is the placebo group and combined carvedilol group, percent improved. There was a trend toward improvement in the regular cardiomyopathy group that you would say was comparable to the adult group. And if anything, it looks as if the treatment group in the congenital heart disease patients did worse. But this did call into question some of our results, because we are seeing that there was a significant difference in the patients as they were enrolled, even though we didn't assume that in our study design. Looking at plasma BNP, BNP is B-type natriuretic peptide. It's a marker of heart failure. Higher levels have been correlated in adults with worse outcomes, and really the placebo group had the biggest drop in the BNP over time, so it didn't really tell us much about loss of BNP in these patients. So the conclusion of the study was there was not a treatment effect of carvedilol. There was a substantially larger improvement in response observed, so a much larger study would have been needed to see response, especially if we had tried to look just at the systemic left ventricles versus the congenital heart disease patients. But it was the first study in our field of pediatric heart failure transplant that characterized the population and showed us quite a lot about the challenges to designing any further studies of heart failure in our group of children. There have been some, so the limitations of this study, as I said, the enrollment took 2.5 years longer than expected. The diseases, the DZ group we included, were expected to respond similarly, and they obviously didn't. The power calculations weren't accurate. Our endpoint determination was not validated, and by the way, 41% of the patients worsened by global assessment. We asked the parents, did you get worse or better, or the doctor, which is a little hard, really, when you're talking about a child who's growing and developing. So that endpoint was not as hard as we would have liked, and the cost was quite high, with a $10 million expense for enrolling 150 analyzable subjects, but they did get their patent exclusivity, and I think in the end, everybody was pleased with the way the study had given us data that was interesting, perhaps not what we had thought to find out. And these are currently secondary analyses going on with the study. As we know, the fallout, the post hoc analyses are not supposed to be discussed. However, they are going to be very informative to us, and I find that in any study I've been involved in pediatrics. We're going to be able to find out a little bit more about death or transplant in this group, whether BNP is valuable. We'll be able to validate our pediatric heart failure class. It never has been validated. And we did get data on the pharmacokinetics of carvedilol in the children, so there were certainly secondary analyses that were very valuable. Last 5 minutes, I'd just like to tell you a little bit how the field has progressed. We are funded at the moment by the NIAID and NHLBI to do clinical trials in organ transplantation in children. This is a network that has been in existence for quite a long time in adults and in the pediatric renal transplant program, and recently they funded trials in other solid organ transplants. And I'm part of a consortium that is looking at the use of transplantation in heart transplant children with a group with Montefiore, Boston, Toronto, Columbia, Philadelphia, and St. Louis. It is a UO1 mechanism, and there is a very strong involvement from our NIH project officer, a research officer, and a separate dating coordinatory center. And to tell you just briefly what we're doing, it's a little complicated because it's heart transplant, it's a little esoteric, but we're looking at, HLA antibodies are what it tells you you are you and what someone else isn't you. And there are circulating anti-H antibodies that people make, and in children with congenital heart disease, they make them more often because they've been exposed with by blood transfusions and often implantation of foreign material. So there are certainly high levels of circulating anti-HL antibodies in our children waiting for transplant. And when they're waiting for transplant, about 15% of them have these antibodies, and there is a danger that they may react to the donor heart the minute it isn't implanted. And the traditional approach to this has been to wait to implant a heart when you know that there aren't any circulating antibodies against the donor. We call that a cross match. We do a cross match, but it turns out that in children, 80% of the children waiting in the hospital are very sick, and a quarter of them are on mechanical support, and waiting has a significant impact on their ability to get a transplant. So that survival after listening for transplant in patients who are sensitized, this is our symbol for sensitization, is about 45% if after the time of listing, compared to better survival if you're listed without being sensitized. Several of the centers, including my former center, decided that we were not going to wait for the prospective cross-match, but we were going to try to treat the patients with anti-H antibodies in a different way to eliminate the antibodies at the time of transplant. And looking at that data, at 5 years after listing, we were able to see a survival of about 70%. So we saw a better improvement in survival because we weren't losing them while they were waiting, but we know that we are putting them at high risk because we are exposing them they're exposing their donor hearts to circulating antibodies. So we have now a protocol with management strategies that include plasma exchange, plasmapheresis, and immunosuppression post-transplant to eliminate the circulating antibodies. And our question has always been, is this going to be effective? And this is the trial that we're going to be doing with the CTOTC's funding. This is a study design. I'm just putting it up. You can't read it, but it's quite complicated because we're looking at so many different groups. We spent about a month on the figure 1 in order before we've been writing on our protocol, and that's what we're now meeting twice a week to flesh out those details. We're going to look at HLA antibody formation pre-transplant. We're going to look at the patients who are cross-match positive, have antibodies against their donor, and look at a clinical endpoint. Compare it to the patients who are not sensitized. And even in the patients who are not sensitized, they make antibodies after transplant, and we never quite know what to do with that information, so that's going to be helpful as well through this study. And now we do have a mechanistic arm to look at antibody production and graft accommodation of these patients, something we've never been able to do in the heart transplant patients. So there are many mechanistic studies associated with this grant, scattered amongst the centers that are participating, the 7 centers. So we'll be looking at many different ways of trying to measure where these antibodies are coming from and how they might affect the outcome of the transplantation from a clinical standpoint. Our timeline, just to show you how this goes, funded in May 2008 and really not starting study till October 2009. So we're going to be a year and a half into the grant, which then of course cuts down into our enrollment period. So there are certainly challenges of working within the NIH 5-year time point, but we're very grateful for the funding. So in conclusion, I'd say that multi-center research studies are essential in pediatric cardiology. That's the only way we're going to answer any questions of any importance in our field. But the small numbers limit the choices of endpoints, and subject enrollment and retention are a challenge. So this often leads to the finding that, yes, we get information, but we might not be able to get all the information that we need to answer the question. We have to do what we have, because we will never have the patients and the numbers of patients that we would need to answer all the questions that we have. And so that data from registries and observational studies is invaluable, and we are really advocating quite a lot to NIH to continue to fund the registries that we have because of their now rich history and their ability to tell us in the long term what's going on with patients 20 years later. What are the future directions? Here, I didn't really talk much about the CTSA here at Montefiore, but I would say that for diseases such as ours, rare diseases, the CTSA is essential. We're not going to be designing large epidemiologic studies, so the support CTSA can offer based on database support, biostatistical analysis, education for our clinical coordinators and our young investigators is something that really can push our field forward. We have an application into the Rare Diseases Consortium that discusses our use of the CTSA here in Einstein to study children with cardiomyopathies. And there is just our two new RFAs out, Pediatric Cardiac Genomics Consortium and Cardiac Development Consortium, and we're talking with Bernice about submitting an application to this in this study, the Cardiac Genomics Consortium. Again, the NIH is realizing the need for collaboration and core resources on a national level, and we're hoping that we'll be able to take advantage of the collaborative efforts with these organizations. So I'd like to thank you very much for having me to speak.